the World Health Organization's definition of patient safety. So a lot of things that you've been saying in your feedback, the absence of preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. And then going back to that point about having no errors, we are aiming for an acceptable, tolerable level of harm within healthcare, because we know that patients in both human and veterinary healthcare do come to harm as a result of providing the healthcare. But how we actually achieve this is very, very nuanced and complex. Patient safety is often only talked about in the aftermath of an incident or an error, and in reality, safety is shaped by a much wider set of factors, from how our systems are designed, to how we communicate, to how teams function under pressure. So my talk today uses the idea of anatomy to break down the different elements that make up veterinary patient safety and how they interact in everyday practice. And hopefully by the end we'll have a slightly broader way of thinking about what safety really means within the context of our veterinary work. So I'm using a framework today which comes from this piece of research, so it's worth briefly explaining where it comes from. This model or framework is based on a study from last year that was by a group of vets and a couple of vet nurses who are all members of the Veterinary Patient Safety Forum, and that is a forum that you can all join to. It meets virtually once a month on the first Thursday. And there are vets and researchers who are in that space talking about veterinary patient safety issues. And they did this piece of research over the last couple of years that aimed to explore how, as veterinary professionals, you conceptualise patient safety. The researchers used a modified Delphi approach, so bringing together a panel of veterinary clinicians, researchers and people with expertise in safety science. And through a series of rounds, the panel worked towards consensus on the key elements that make up veterinary patient safety and how those elements relate to each other. The final output of the research was this visual model that highlights the different interconnected components. I know you can't all see that on the screen. We're going to go through this and break this down in much more detail. But it covers the people, the behaviours, the non-technical skills, systems and processes, and the disciplines and approaches that all underpin safety thinking. And rather than presenting patient safety as a single intervention or a single policy, this model shows it as a complex system where multiple factors interact to shape outcomes for patients. So what I'd like to do today is to use this framework as a way of exploring the different anatomical systems of veterinary patient safety and thinking about how they interact and play out in our everyday practice. So thinking about it in anatomical terms, looking at the different systems that make up the body of veterinary patient safety. So if veterinary patient safety had anatomy, this is where we'd need to start. The skeleton, which represents our systems and our processes. They provide the structure and stability of our work, and without them, everything collapses. And there are many different systems and processes that we can introduce and use in our work that help provide this structure. Briefs and debriefs is one good tool that we can use in practice. So the briefs we can do at very different parts of our day. So at the start of our day, during handovers, when we have a change of team members, during any huddles or rounds that we might have, at the end of our shift. These sort of processes are through our day when we can have a brief handover, communicating among our team. And also before we start a procedure, particularly if we're having a complex case, so having a briefing before those cases, and before an emergency arrives, before what we know about the patient before they get here, having a brief, getting ready and preparing for that emergency. The important thing is to, in that briefing, thinking about what's different about today, about this patient, about this procedure, what we need to pay attention to as part of that briefing. And then debriefs are after an event. So a hot debrief is normally after some sort of critical event, so a patient safety incident or a CPA, an unexpected patient death, or a significant adverse event. Having that immediate hot debrief with the team there, getting them together and working through in the immediate aftermath what's happened, what can we make sense of, and what do we need to do to ensure safety of any other patients, for example, but also to support our team and to process what's just happened in that hot debrief environment. And then cold debriefs are normally a bit longer after an event. So going back and reviewing a complex case or a distressing situation or patient that the teams had to cope with, and thinking about that as more of an educational setting. What can we learn? What can we reflect on? What could we do differently in future? And after any sort of new and novel procedures, how did it go? What went well? What didn't go so well? What could we do differently? So briefs and debriefs are definitely one of the strict systems that we can use to enhance safety in our practice. So So next question for you, checklists. Do you use checklists? This should be a multiple choice question within our Slido. I'd love to know what the answer to this is. So your options there are always, sometimes, rarely, or never. So the vast majority of you either always are using checklists or sometimes using checklists. And the much more few of you who are rarely or never. That's actually probably, if I'm honest, probably a better picture than I thought I might see today. So I'm really, really glad to see that you are. The reason I talk about checklists as one of our systems and processes is because they work. All of the research on the efficacy of checklists shows a massive reduction in harm to patients. The studies of the WHO surgical safety checklist that came out after it was introduced showed some really big numbers, and to the point where actually the people who brought it out, who got the initial feedback and study results back, had to go back and double and triple check the numbers. They couldn't believe how much they actually worked. They reduced mortality by 47%. They reduced major morbidity by 36%. So I could go on all day about checklists and how wonderful they are and why they work and how they work, but the really key message here is they do work, so we should be aiming to use them. At the Ralph, we use them. We have many checklists, in fact. So these are some of the ones we have. Pre-induction, before we start the case. Before we prep the case, obviously make sure we've got the correct site for the operation that we're doing. Pre-procedure, before we make the first incision, there's another checklist at that point in time. And then post-procedure, making sure we're counting things like swabs and sharps and things like that. And then we have some for different specific procedures. Different teams within our obviously specialist hospital have their own nuanced checklist for different scenarios, such as endoscopy, central line placement, dentistry, chemotherapy, ophthalmology. All have nuances in the work that they're doing, so have their own special checklist as well. And also things like a discharge checklist for before a patient goes home, have they got all their drugs? Have we made sure they're washed and groomed and presentable before they actually get discharged to their carers and to their families? This is an example of our pre-induction checklist. Again, you probably can't read all this if it's too small, but as an example of things we cover, before we pre-med, patient ID, who's assigned to monitor the patient, are they being barrier nursed for any reason, have we got carer consent, what's their resus status, and have we got a patient IV placed. And before we actually induce the anaesthesia, again, checking the patient ID and procedure that we're doing, including the site as appropriate. Our anaesthesia equipment and monitoring machines, are they all set up correctly? Have we got all our pre-med drugs available? And then before we proceed, assessing the risk to the patient that we might have. So have they got a difficult airway or a risk of blood loss? Have we got any allergies? And then lastly, is everyone ready? Have we got our equipment ready, our teams ready? Any concerns in the room before we proceed? So of all the checklists, I think this is probably the main key one that we use day in, day out. Another system and process that can support patient safety is clinical audit. And that is essentially measuring the services we provide against best practice, evidence-based guidelines and standards to improve our patient care and outcomes. So how do we know we're providing the best care that we can? Audit is one way of answering that question. So there's two types of clinical audit. The first is process audits, and that's essentially how do we deliver our care? What are we doing within the actual hospital or practice? And examples of that could be the timing of prophylactic antibiotic administration. Is it within the correct time window that's recommended? Are we countersigning all of our medications? That's good practice as well, to have double signatures on all our medications that are dispensed. Are we compliant with hand hygiene or infection control standards? These are all process audits that we could undertake in practice to make sure that we're achieving and delivering high quality and standard of care. Outcome audits, though, are more around what actually happened to the patient. Did we achieve the desired outcomes from our intervention, treatments or procedures or medication? So examples of that could be things like infection rates. Also things like carer satisfaction. Do we ever get feedback from our clients' carers on how they actually are interacting with the care we provide? And also things like, for chronic patients potentially, things like quality of life tools to monitor and track clinical outcomes over a longer period. And there are also national registries for these audits like this. There is the National Canine Cruise Ship Registry as well, which tracks outcomes from surgery across the whole country for that procedure to see what the outcomes are like for different techniques and settings as well. So process audits are easier to implement because they're things we can more easily measure within practice, but outcome audits are really important too to see if we are delivering the benefit for our patients that we want to. So our next system and process is going to be patient safety reporting. So another question for you. Do you have a patient safety reporting system in your practice? The options you have are yes, no, and I don't know. Again, I'm really keen to see what's available in the room, what you're actually doing in your own environments. Probably what I expected. So yeah, 40%-ish, you do have something. Almost the same, 35% don't have anything, and some of you don't know. That's a question for you. If you have got a system, have you ever submitted a patient safety report? That is more like what I expected to see, actually. So yeah, around almost 2/3 of you have not submitted a patient safety report. I won't ask this question, but I know the answer to it. Have you ever been involved in or witnessed one? I would say, arguably, I've not met a clinical person in my life, human or veterinary, that hasn't been involved in a patient safety incident. Even a basic medication error counts as one of those. So the link between experiencing patient safety events and reporting and addressing them is still something we need to strengthen in our veterinary setting. For those of you who have, the 30% there that said you have submitted a patient safety report, one final question. Did you receive any feedback? Did anything change as a result? And again, your options there are yes, some feedback, or change, or no. So just over half of you have seen some feedback and change. That's really, really good to hear, actually, because that's one of the really key drivers to encouraging safety reporting behaviour is actually people having at least some feedback as to what's happened as a result. It might be nothing. Maybe there's nothing we can do about this to change this thing or to improve this thing, but we have looked at it, we've investigated, we've thought about it, but unfortunately we can't change anything. Even that in itself is feedback. It's worth reporting something because there's at least someone's looked into something and tried to see if we can improve it. So event reporting is really important because it helps us to identify events or near misses that can help us show weaknesses in our system that we want to do something to address. We can then try and understand what's happened and why, and then share that learning across our teams so it doesn't just stay with one person, it's actually a team-based response to things, and ideally leads to changes that prevent the same situation happening again in the future and prevent reoccurrence of the same issue. But there are many reasons why people don't submit patient safety reports, other than not having a system in practice at all. That's a real barrier to reporting if you haven't got a system to report, which we can reflect on. But if we have got systems in practice for reporting, how can we help people to report patient safety incidents? So this is the COM-B model for behaviour change. You identify a target behaviour that you want to change. So in this instance, we want people to report patient safety incidents. And the COM is the capability, opportunity and motivation for reporting. So capability is thinking about the knowledge, skills and ability, be that physical or psychological. So essentially, do people know how to make a report? If it's an IT system, can they access it? Have they got login details? If it's a physical system like a book, do they know where it is? Or forms online, things like that. Do people know how to make a report? Do they know what's expected around reporting? Do they know that we expect a medication error to be reported? Are they clear on what is a patient safety incident in the first place? The opportunity is more about the access and the external factors, social things, physical things. So basically, how quick and easy is it to make a report? If you have got a system in practice, is it easy to access and log into? Do you know how to find it? Does it take a long time? Can people on the clinical floor do it while they're on their shift? We've paid a lot of attention to this at the Ralph and have really increased our reporting numbers over the last couple of years through bringing in place an easier way of reporting things using a Google QR code that links to a Google form. We still use Vet which is the system provided by the VDS to manage patient safety incident reports. But we use that as well as an internal system first that makes it easier for particularly people on the floor to scan a QR code quickly and easily, no login details, and then submit the report that we can then put into VetSafe and then deal something with. And then lastly is the motivation. Do people want to submit reports? And a lot of that is around what I was saying a minute ago about what actually is the response to a report. Do you respond with the right attitude, with an opportunity of learning and curiosity as to what's happened and why? Or do you respond with negativity and blame? The different response will definitely influence how people report in the future. And also, so will feedback and evidence of change. If things are heard and listened to and looked into and change and improvement is explored, people are more likely to want to report things in the future. There's also reporting things more often means we can pick up trends and themes. Even if they're quite low-level incidents, you can get themes that will emerge. And there are other systems and processes in the framework that I mentioned, that visual diagram, that I won't have time to go into today, but there are things like clinical governance, our communication structures, how we approach quality improvement in practice, different influences on our organisation, what's our regulatory requirements, practice standard schemes, things like that, how we try to work towards a just and learning culture. That could be a whole talk on itself. Then things like our protocols, our guidelines, our SOPs, they're all parts of our systems, as well as how we design our systems and the way we work in our task design as well. These are all things that we can pay attention to as part of that skeletal framework of our patient safety anatomy. But skeletons don't move on their own. They require muscles to move, and muscles are like the behaviours of patient safety. How we actually act inside those systems, because you can have the most beautiful SOP in the world, but if behaviour doesn't align with that, then nothing's going to change. The key behavioural muscle groups of patient safety are structured in this way. So we have civility and respect, which are very much linked, and then learning and reflection. And these behaviours shape how teams interact, how we respond to problems, and whether we can improve over time. Some of you may have be aware of the Civility Saves Lives campaign. It was a campaign led largely through the human healthcare setting, following an extensive amount of research on the impact of incivility in the healthcare workplace. And the research, some of the findings I've included here, but there's much more out there if you want to look into the campaign more widely, that when we perceive incivility, it reduces our cognitive ability, our ability to think. It reduces our time and commitment to the organisation, makes us less willing to work as a team together. It can drop our diagnostic and procedural performance, and it reduces our willingness to share information and to seek help. So behaviours like civility and respect aren't just about being nice and having a pleasant workplace. They actually directly influence how safely teams function and ultimately the care patients received. The campaign is called Civility Saves Lives for a reason, because it's been proven that civility does actually improve patient outcomes and does save lives. The other behavioural elements in the model were learning and reflection. We know that healthcare is very complex and unpredictable. Things won't always go perfectly. But it's shown that teams that briefly pause to reflect are more likely to identify improvements that prevent future problems. This could be through things like short debriefs, case reviews and discussions, discussing things like near misses, those moments of, phew, that almost went really, really wrong. So we stop and discuss that about what caught it and what we could stop from happening again. I always think of this phrase, a different patient, different day. Didn't affect that patient today, but it could be a different patient tomorrow or a different drug tomorrow that could be a different outcome. This model here is more of a personal reflective model. It's the Gibbs reflective cycle. I really like it as a good tool to use for personal reflections. If you do these, you can feed them into your CPD systems as well. To think about an event that's happened. Could be positive or negative. It hasn't got to be a negative outcome. It could be a really great case that went really, really well. What happened, what we were thinking and feeling, what was good and bad, what sense we could make of it, what else we could have done, and what we would do differently or the same if it happened again in the future. So a good model for reflection there too, that I recommend. So these behaviours, these muscles we want to see used are things like following checklists consistently, or trying to introduce them in the first place if we're not using them, speaking up about concerns and normalising that as a behaviour within our practice, things like double checking high risk steps, so medication administration and drawing up and administration, asking for help early on in an issue of the process, and then holding those debriefs after complex cases so that we can learn about what's happened. But doing these exercises and exercising these muscles, daily, weekly in our practice helps to normalise those behaviours and become part of our norm. But a question for you. Come on, move. So again, on your Slido, what gets in the way of performing these behaviours consistently? Lots of great feedback there. Thank you. So some practical suggestions that I can offer to try and minimise some of those issues and barriers to the behaviours you want to demonstrate. Trying to build habits into routines where we can. If you have a daily team meeting or team huddle, can we bring in like a briefing process as part of that? Thinking about what our structures, our routines are, and building these behaviours into those structures already rather than creating new extra things to do, given that we have less time available. With checklists, even if we haven't got full checklists, we can have things like micro checklists for some high risk tasks. That might be 3 or 4 points long, and that can be much more easy to access than more in-depth, complicated checklists potentially. Keeping things visual, having prompts and posters around the practice that indicate things that we want to do more of, such as reporting a patient safety event, could be something we have a poster campaign for that can help, again, signify and indicate this is our expected behaviours that we want to happen. To encourage the open dialogue and normalise speaking up. A lot of that comes from you as leaders as well, by, again, normalising that yourself and inviting questions, inviting people to escalate and raise concerns. If they see something that is worrying them, to say before you start a procedure. If you see something that worries you, that you're concerned about, please speak up. I welcome your views and feedback. And to not worry about your authority or your decision-making being questioned or threatened. Actually invite curiosity from your team members if they see something or are unsure about something. Developing some simple SOPs for high-risk tasks, which could be things like giving a blood transfusion, for example. How do we do that in a way that we've got a standard protocol for? And having these short micro debriefs after a tricky case. It's something we can quickly and easily implement. That we've had this really one. This case didn't go as we planned. Might not be a patient safety event, but could be something that didn't go quite as we wanted to. Had to have a little quick debrief to see what we can learn from that. And then in your team structures, trying to rotate responsibility of who is the leader in the moment, to give other people in the room a chance to lead as well, and to have different people take turns, for example, when doing a rounds or a huddle or a debrief. So different people are speaking first. It isn't always the most senior person in the room. That normalises that behaviour of everyone's voice matters and contributes. So our next system is the nervous system, which relates to the non-technical skills, which are the nervous system of patient safety. And they coordinate everything in real time. And when our nervous system is overloaded, performance degrades. There are several non-technical skills. There are many more than I'll talk about today, but I'm going to touch on a few that really matter and then ask you some questions. So the first is decision-making is a critical non-technical skill. How you're making those choices in a safe way, particularly when you've got uncertainty. So things like choosing the right diagnostic tests, weighing the risks of sedation versus anaesthesia or something like that. Which emergency you're going to prioritise first. That's a decision-making process, obviously. These things are probably more closely linked to your clinical training, but it is still a non-technical skill outside of the clinical environment as well. The next is situational awareness, being aware of your patient, the environment, your team, and what risks there are today for this patient, this procedure. It's something that can go quite quickly when we get into an emergency situation or things start going a bit wrong. Our awareness of the situation can decrease very rapidly, particularly things like the passing of time can go very, very quickly. If you've ever been involved in crashes, then time just goes so quickly. So being able to have good situational awareness and having things that we can drill in to help that will come on to, but noticing if your patient's deteriorating, could be quite subtle signs. Thinking ahead before a procedure, what complications could we anticipate, so we're aware if they do arise in the moment. And again, that passing of time, having people assigned as a role to be a time caller if something was to go on, say it's been 2 minutes, it's been 4 minutes, and to highlight how much time is passing. Communication is critical to everything. In my patient safety investigations, one of the most common things that I find as a learning point is that communication has broken down or fallen down somewhere. Making sure we have that clear, concise exchange of information with our team and with carers, as we call them. And that includes having really effective handovers. And by that I mean also using a structure and doing it in writing. There's some really good research on the amount of information loss at handover from a verbal-only handover compared to one with note-taking. It is incredibly different how much information you lose in those two different scenarios. So having good handovers, making sure we're explaining risks to carers the best way that we can, calling for help early in emergency situations, and also paying more attention to our interprofessional communication. I think some of the communication skills through vet school focus on carer communications, less about how we talk to each other and to do different roles in the team. So communication is definitely a critical non-technical skill. Come on. As is leadership. So how we guide our team and take responsibility for the outcomes that we achieve. So leading sort of day to day, so how we coordinate preparing for surgery or delegate our tasks to our team members, maintaining calm and running those emergencies. but also leadership in terms of modelling behaviours as well. So the behaviours and the muscles that I mentioned earlier, as leaders, we can affect our whole practice and the way the whole team performs those behaviours by modelling those leadership behaviours. And then teamwork, having a good collaborative, supportive interaction with team members. I ask people on my new starter inductions about what things make a difference to them having a good day at work, and teamwork nearly always comes up as one of the real positive things that can make the difference in their day, regardless of the outcomes we get for our patients. So making sure that our whole care team is working together, we're sharing observations and issues that arise, we step in to assist each other, and also looking after each other's well-being, because how we are feeling on a given day, if we've come to work and we've got a headache or haven't slept well the night before, or feeling stressed about something, our upcoming exam or something, being aware and conscious of that among the team helps us to pull together a bit tighter and to improve our team working ability. So another question for you. Have you ever done any training or CPD in any of those skills? Potentially definitely some room for improvement, some extra CPD. There is lots available out there in these skills, particularly around communication that isn't carer-facing. Things like appropriately assertive communication or closed-loop communication are good things that we could do CPD and training in. Next question for you, though, is which of these skills do you feel most confident in? So it's looking like a lot of you feel really, really confident working in your teams. That's great to hear and great to see. But some less confident in some other areas, particularly in leadership. Something that I've observed in my healthcare career, both in human and now in animal medicine, is that clinicians train to be excellent clinicians and then move up into positions of leadership and get no training or development in leadership skills. So definitely something, if you're in a sort of role where you're progressing through a leadership or a management kind of structure, to seek out specific leadership CPD, because there are skills and tools within that toolbox that you definitely need to be a better leader. So some tips and tricks for you. So for decision making, using structured decision aids, if you have them available, so clinical algorithms. For example, we have our emergency drug doses already put on our crash trolleys, so we have those ready prepared, for example. Discussing complex cases with a colleague, rather than keeping things in your own head, talking about things out loud, or if need be, contacting your local referral centre for advice if it's a really complex case. We're always happy to help in those situations. For situational awareness, taking a pause, just to stop before we start doing something, to prepare and scan the environment. Asking those what's different questions, again, what's different about today, about this patient, about this procedure, and using those checklists for high-risk steps can help us increase our awareness of what we're about to go into. Communication, standardising our handovers, making sure they're written down, using closed-loop communication to repeat back important information when we're giving an instruction or a request to somebody to give a certain amount of a drug, for example. If someone repeats that back to you, it means that you're both on the same page, you've both said and heard the same thing, reducing that miscommunication. Clarifying instructions with carers. Carers can often be quite overwhelmed and have a lot of information to absorb and take in, so things like post-discharge instructions, post-operative instructions, medication administration, physiotherapy requirements, making sure that's all communicated clearly and documented so carers can reference it and have access to come back to you and ask follow-up questions. And then using structured tools. So SBAR is a handover tool. It stands for Situation, Background, Assessment and Request. Very, very simple framework to use when giving a handover to a colleague. And then CUS and PACE are both assertive communication tools, appropriately assertive communication tools. I haven't got time to go into them today, but you can look them up and Google them. They're widely available to help escalate a concern in a non-threatening, appropriate way where the concern is perceived and heard by the person you're escalating it to. And communication is one of those topics where you can have there's a lot of workshops and training and CPD available for. And our next system, at the centre of it all, is the people. People are like the organs in the system, in the body. They do the actual work and carry the load, but are vulnerable to strain if overloaded. As people, we're not mechanical components. Patient safety depends on human beings, which means it will never be perfect. Human beings are not perfect beings, therefore our work and our interactions can't ever be completely perfect. Recognising and respecting the roles, who are all like different organs in the body. They're all essential for the functioning of a practice and essential also for patient safety. But even the most experienced person can make mistakes. As I said, we are all human. So my next question for you is, which factors in your day-to-day practice make errors more likely? Staffing levels, caseload, workload, tiredness, sleep, absolutely, fatigue. Yeah, lots of factors there, and everyone's affected by these factors. It's not just someone else's problem. So building our systems and culture and teamwork can help mitigate these vulnerabilities. So what I've already talked through, the skeleton, the muscles, and the nervous system that I've mentioned, these are all good strategies to help employ together to help mitigate this. Because just like organs being under strain, people are more vulnerable when these factors accumulate. Our role is to design a system where all organs and muscles and nervous system interact and work together and pull together. And finally, the DNA. This relates to the disciplines and approaches to patient safety that we can employ. As we know, DNA is the underlying blueprint that shapes everything else, that impacts the people, the behaviours, the skills and the systems. And if your safety DNA is blame focused, then everything will grow defensively. If your safety DNA is learning focused, everything will grow adaptively. There are many, many different disciplines that contribute to patient safety. And again, it could be a whole talk in and of itself. I have done whole talks on some of these in the past. Please check our the Ralph website, the Library and Learning page, have lots of different past CPD talks where you can look at some of this stuff in a bit more detail, but I'll highlight a couple of them here just as a high level. So the first being human factors. This is my job title, but what is that? Essentially, it's a science actually of understanding how humans interact with systems, and systems are everything we interact with and touch and engage with to do our work, essentially. So that's people, that's the environment, that's equipment, that's carers and clients. And it's how we design those systems and the tasks and the equipment to match us as human beings and our limitations as human beings. A lot of that can focus on ergonomics, so the physical design of objects and equipment to make it easier to interact with, and things what we call like human-centered design. You can probably all think of a piece of equipment in your practice that doesn't really work as you'd like it to, or is a bit more clunky to interface with. But it's also about our tasks and our processes as well, our protocols and how we design our work as well. To essentially distilling human factors into one sentence is making it easy to do the right thing. How can we make it easier for the person who next does that task to do it the right first time? That is a huge topic in one very small nutshell. Our next topic was psychological safety. This is, again, really, really critical. It is the definition here is not mine. It's from the research on this very broad topic again. It's the shared belief that a team or a workplace is safe for interpersonal risk-taking, that we allow members of the team to speak up, to admit mistakes, to ask questions, and propose new ideas without fear of punishment or humiliation. There's a lot in that sentence, but again, that shared belief is from the whole team. It's not just individuals feeling safe, it's does everyone feel safe to speak up? Do we encourage questions? Do we humiliate or punish people for mistakes, or do we actually showcase that I've made mistakes too, let's learn from it? It's a demonstration day to day that we are open to learning from errors, and we want to learn from errors, and we will learn from errors. Systems thinking, again, that's a whole discipline of itself that I've done some specific qualifications in. It's viewing, well, I said healthcare here, but systems thinking comes from industry as well. It views the environment as a complex network of interacting parts. Particularly in healthcare, it's very, very complex. Looking at the people, the technology and the processes that are involved in providing healthcare, but importantly looking beyond individuals and looking at that wider system when something's happened to reflect on what were the conditions that enabled this to happen and why did it make sense in that moment. Bearing in mind that as clinical professionals, I would hope you never intend to cause harm to your patient or to make an error or a mistake. These things are always generally unintentional. Therefore, it's fruitless and pointless blaming that individual or pointing fault at an individual. We should look at a more broader context of what were the conditions that enabled that thing to happen and what therefore could we do differently in the future to minimise the risk of that happening again and make it easier for that person to do the right thing the first time again, linking it back to human factors as if these things all interconnect and interact with each other. So yeah, systems thinking is another important one. And then we have, move on? Safety 1 and Safety 2. These are both safety science disciplines. They are different but interrelated. Safety 1 is where traditionally safety science has focused in the past. It's been something's gone wrong, let's investigate it and try to put something in place to minimise it happening again. And that's come from like health and safety as well in the past, workplace accidents, things like that. But as you can see from the diagram here, that is really minimally the work that we do. Things thankfully don't go wrong all the time. They do, but not as often as they go right. So Safety 2 is focused more on everyday work, looking at when things do go as we expect and as we intend them to, and trying to learn from that and to say, how can we make this go well more often? How can we repeat this more often and make sure that we're maximising and learning from the things that go well also? And you need both of these approaches, but they do complement each other and really pull together to have a broad safety focus. There are some other disciplines and approaches, again, that the framework mentions. Things like being human is a training discipline that picks up things like systems thinking, human factors, psychological safety in a training programme. The science of human performance is massive. Again, comes from things like sports coaching in the past, about how we can maximise our performance as individuals. Things like marginal gains are part of the science within that. And then things like wellbeing and health, workplace culture, as you've alluded to in some of the answers to your questions today, these things really matter and affect our ability to do our work as we want to exhibit the behaviours that we want to as well. So just to recap on all of that, so our anatomy of veterinary patient safety, we have the skeleton, our systems and processes. Those are our structures, our SOPs, briefs, checklists that help us to structure our work. Then our muscles, our behaviours that enact that stuff, so speaking up, double checking, asking for help. The nervous system of our non-technical skills that coordinate everything, those things like decision making, communication, teamwork and leadership. Then our people, who are like the organs, how we work together as individual roles but contributory roles to actually help each other to achieve our outcomes. And then the underpinning DNA, those disciplines and approaches that if we can weave them into how we integrate our work and our practice will help to support and underpin everything else.